Hello, I want to thank the ABEA for allowing me to present today in-office botulinum toxin injection for RCPD, how I do it. I think it's very important when doing this procedure to inform the patient about the operating room and the office and let them choose whichever procedure seems better for them. We all know how to consent patients, so I'll stick to the pearls. When discussing the operating room, I let them know the whole procedure is about 45 minutes. It is under general anesthesia. In the operating room, I can pull the voice box away from the cricopharyngeus and inject on both sides at the same time. With that, there's a 90% chance the patients will be in the happy zone afterwards, which means minimal to no symptoms. There is a 10% chance that nothing's going to happen, or it'll be 30 or 40% better, 60% better, whatever it is, that we'll have to repeat the injection. On average, the swelling is worse in the operating room than in the office, and obviously someone will need to take you home. In the office, there is no anesthesia, so the patient can come and go quickly without a companion. It takes less than a minute to do the procedure. The difference is that in the office, I cannot pull the voice box away from the cricopharyngeus, so there's about a 1 to 2% chance the patient can be hoarse for 4 or 5 weeks if we weaken one of the PCA muscles. That's not a huge deal, but if we do that bilaterally at the same time, they have difficulty breathing, so we can only do one injection on one side at a time. The good news is that 70% of the patients only need one injection to be very happy with the result. The way we handle that is we have the patient come in, do the first injection. They'll send me a portal message 2 or 3 weeks later. If they're doing great, they're done. If they're doing 30%, 40, 50, 80%, 0% better, they'll come back in within 8 weeks of the first injection. We'll look in their nose with a camera, make sure the first vocal fold's moving, and then safely inject the other side. 19 out of 20 patients say that the injection is much better than they thought it would be, that there's not much pain, a little bit of pressure, and occasionally pain in the ear. Between 1 and 2 injections, 90% chance that this will work and the patient will be satisfied. 10% chance we'll need to go forward and do another injection. For that, I usually recommend the operating room. I will reiterate the differences to the patients and emphasize that, again, the dysphagia is worse in the operating room than it is in the office. In-office treatment is 1 to 2 injections with about a 1 to 2% chance of having dysphonia. There's a 30% chance you'll need a second injection if you choose the office option, 90% chance that either injection will work for you. How do we do the injection? I mark here the inferior border of the cricoid and then mark along the anterior border of the SCM at about 1 centimeter above and 1 centimeter below. Typically, the injection will be done at the upper marking, again approximately 8 to 10 millimeters above the inferior border of the cricoid. Occasionally, it'll be at the inferior border of the cricoid. Very rarely will it actually be below that. The EMG settings are the same as you will use for your Botox injections, with a low filter of 20 hertz and a high filter of 10,000. The amplitude is between 50 and 100, and the sweep speed is 100 milliseconds. I will go in, tap the thyroid ala, and walk the needle back until I drop in behind the thyroid cartilage. But instead of curving in as you do to approach the PCA, you'll just go straight, and that will drop you into the cricopharyngeus muscle. When we're in there, I'll have the patient sniff to make sure that I'm away from the PCA muscle, and have them swallow so we can hear the EMG have silence during the swallow, and then a large recruitment as the muscle again contracts. And we'll inject 30 units of botulinum toxin in 0.3 mLs. This is a very good tracing. You'll see that there's very wide motor unit action potentials for this muscle compared to those that we see in the endolaryngeal muscles. When the patient swallows, there'll be a dropout and a silence, and when the patient sniffs, you won't hear the PCA. Swallow. Sniff. Great, let's watch that once again. Swallow. Sniff. Here's another tracing. That's not quite as good. You'll still see the wide action potential, but there's not as much recruitment. But when the patient swallows, you'll get that silence, and again, the action potentials that you'll see fire when the muscle contracts, again, knowing that you're in the PCA. Swallow. Right, so big wide action potentials, silence, and then the crash on contraction. One more time. Swallow. So that will still be a successful injection, and this is how we do it. Again, look for the tapping of the thyroid ala, the silence on the swallow, and no action potential with a sniff. All right, so we're gonna go in there. When I'm in there, I want you to just do 2 quick sniffs. Okay, so practice that like this. Perfect, and I'll probably ask you to swallow too. Okay? Pick your chin up a little bit. Good. Great. Sniff. Swallow. Let's watch that once again. All right, so we're gonna go in there. When I'm in there, I want you to just do 2 quick sniffs. Okay, so practice that like this. Perfect, and I'll probably ask you to swallow too. Okay? Pick your chin up a little bit. Good. And you'll see the tapping of the cartilage right there, dropping in behind. Great. Sniff. Swallow. And that was the silence with the return of the action potentials. This is another injection, which was not quite as good at first. We'll go in a little bit higher, don't really get the signals we want when the patient swallows, repositioning, and then you'll see it. Sniff, swallow. All right, so nothing happened on the swallow. Position a little lower. Sniff. Swallow. And there's the silence. So that's it. Thank you for your attention. If you have any questions, please contact me.